You ready?
Whenever you are, Christina.
Okay. Good morning, everyone. I am super excited to introduce you all to a colleague and friend of mine, Dr. Tony Thrasher. He is the Medical Director of Crisis Services in Milwaukee County, as well as the immediate past president of the American Association of Emergency Psychiatry. He is the current president of the Wisconsin Psychiatric Association and the Wisconsin Association of Osteopathic Physicians and Surgeons, as well as clinical associate professor at the Medical College of Wisconsin. He has a number of other jobs and titles. So I was going to hit the highlights. I really appreciate your time and you being here to speak with us about high acuity documentation.
Thank you so much. I really appreciate the invite. I love meeting with people to talk about this topic for two big reasons. One, it's a passion project of mine, which I think you will pick up on as we talk for the next 60 to 70 minutes. Also because I'm a firm believer in kind of always educating oneself. And the more I talk to other groups of people about this across the country, the more I learn about it and the more changes I can make to this particular educational piece. So I really appreciate your attendance. I encourage you to ask questions either now or even later. I also encourage really critical feedback. At the end of this, once you've thought about it, there's some things you want to go into deeper detail or you think I should possibly consider or alter. I welcome all of that feedback and more. So as Dr. Terrell mentioned, my name is Tony Thrasher. I'm a psychiatrist in Milwaukee. And today I get the privilege of talking to you guys about one of my favorite topics, which is documentation. And not just documentation, but the hard documentation, right? I really got into this about a decade ago because I was overseeing a lot of different residents, fellows, other scopes of practice, NPs, PAs, nursing students, social work interns. And what I found was most of them knew the right decision to make, but they were somewhat intimidated by making that decision because even though they knew it was right here or right here, they couldn't think of a way to document it in a way that made sense. And so in an odd sort of way, they were going against their own best clinical judgment out of fear of documentation. So that's when I kind of started my own personal journey on doing a deeper dive into what we should and what we shouldn't write. And that's kind of what today's talk is about. I'm going to really focus on some phrases we should try to avoid, and then I will give you some reasons why and some alternatives. And this is not meant to be the end all be all. There's a lot more to be said on this topic, including things like the open note era, which we can get to maybe at the question stage. So I think this is one that hopefully will have a lot of things to discuss. It's not only pertinent now, it's only going to get more pertinent as your career progresses. Here's my contact info. The email is the best way for me. By all means, if you have a question, but you don't want to ask it in front of the group, I understand. If you have a question that you don't think about until 3 days later, like I do, email me, let me know where we met, and I would be happy to chat with you on it at a later time. And speaking to today's talk, I welcome questions as we go. I'll try to keep my eye on the Q&A box upstairs. Every once in a while, when you're in presenter mode, it kind of fades out on you. And so if that's the case and I miss it, I'm not ignoring your question. It just means I didn't see it. And I'll make sure to get to it when we get to the end as well. These are my organizational disclosures. These are groups that I belong to, but I am not compensated by. However, they affect my voice. They are who I represent, and so therefore I always disclose them. These, however, are work products for which I do receive income. None of them are tied to today's talk, so there is no conflict, but I still list them as I think it's only fair for you to know what your speaker is involved with or connected to. All right. Three big things. We're going to talk very, very briefly about the need to embrace high acuity documentation. This is not meant to be a talk on risk assessment, management, and mitigation. We could do that some other time if you want. I'm going to assume you guys are doing the right risk assessment. This is all about how do we document it? How do we phrase it? What should we accentuate and what should we minimize? And to do that, what I'll really do is mostly number 2 and number 3. We're going to go through a top 10 phrases that I think you should be cautious with, and then really talk about the evidence behind that and give you some plausible alternatives that could be better, not only for you, but also for the patient. And this is the real challenge, right? The first challenge is to protect yourself and not put anything down that could affect you, your license, or your reputation. But also, as we move forward, how could this documentation be our transitional object? How could this be used as a way to bind patients to us, empower them, give them hope? It's a very big challenge that I just threw at you, but I think it's one worth considering as we move forward in the era of the open note. Couple disclaimers. I'm not a lawyer. Most of my work through my entire career has been high acuity, what I call ICU psych. So I'm used to the forensic world. I have a lot of work with lawyers in the courts. I will be speaking to that today, but I'm not a lawyer. I'm not your lawyer. This is not legal advice. I never thought I would ever have to have a slide on this till I saw a couple court transcripts where I was referred to as Attorney Thrasher, and that made me put this slide in, because I am not. So this is our one benchmark slide. Then we're going to move past it. We are obviously living in an arena right now where suicides are on the rise. Violent events, not so much. That particular bullet point's a little bit outdated. Most violent events in 2023 are going down. Mass shootings are one exception to that rule. But suicides, unfortunately, continue to climb. And I think the other really important thing that is for people like myself that have been doing this for a while, I've seen this change. When I was a resident many, many decades ago, when we thought about suicide assessment and high acuity, we didn't think about all psychiatrists. Thought about inpatient, maybe ER consults, and forensic folks, because that's kind of where all of these cases, we had a different system. Things were set up differently. People were seen in different places for longer periods of time or shorter periods of time. Now we are in a world, better or for worse, where we evaluate risk has changed. And so I would argue, no matter where you're coming from on this call, I don't care if you're early career, late career, if your plan is to be inpatient, outpatient, partial, IOP, forensic, Jerry, child, FQHC, virtual only, locums, travel. I don't care what you're going into. This is a very important topic. I think it's well worth your time and effort, not just for this hour with me today, but I think big picture to think about. How am I doing on my documentation? How am I evaluating it? Where is it going forward? Because I do believe it's going to be one of the big things in our field over the next 5 to 10 years, if it is not already. Now, this next one is tips from a good colleague of mine and Dr. Terrell's, Dr. Jack Roselle out of Pittsburgh. This is my take-home slide. This is how you don't get sued, so be ready. First up, do not be the estate or executor of a deceased person. Do not be a business. Do not be a governmental entity. And I cannot stress this enough, do not be a person. As long as you satisfy all 4 of these criteria in their completeness, you will not be sued. And while this is meant to introduce a little bit of humor to your morning, there's also truth in it. If people are focusing on how I don't get sued, which I get that question weekly, I always say you're missing the bigger point. In fact, concentrating on how do I not get sued, I have found in my career makes you more prone to getting sued. Your focus should not be on the litigation because we live in a very litigious society. We also live in a country where the legal system is somewhat geared to give the benefit of the doubt to the person seeking damages. And so there's a high chance that most everybody on this call will be named in a lawsuit somewhere. It doesn't mean you're going to stay on the lawsuit, nor does it mean that the lawsuit is going to be adjudicated against you. What you really want to focus on, and I'll get to this at the very end, is doing a complete job covering your bases and documenting it thoroughly. That way, even if you were to be litigated against, you don't stay on the suit very long. So we are all people. We are not terminators. Let's move forward. Top 10 list, no particular order except for the very first one and the very last one. I did pick those on purpose. Everything else could be mixed between 2 to 9. I'm going to give you some studies so you know this is not just my personal opinion, and then offer some what I like to think are very plausible alternative things. Nothing irks me more than when people tell you not to do something and then don't give you some other way to do it. That's really not fair to any of us as medical decision makers. So here we go. First up, for a very clear reason, patient has no SI, HI, AHVH. First of all, I'm not saying not to use this phrase. You can use this phrase. However, this phrase is not risk assessment. And I've seen a lot of good doctors go down in the courts over this one. They'll say, hey, doc, please point to me. You've got the chart in front of you. Where is your risk assessment of this individual? And they point to this. This is not considered risk assessment. This is an objective finding of your mental status exam, right? This is analogous to auscultation. A cardiologist would not say, you know, no murmurs and say that was their cardiac exam. That's analogous to what we're doing here. So by all means, you can use this. You can continue to use this, but please don't ever make this your closer. Don't refer to this as risk assessment. It is not seen that way, not by the courts, not by your medical oversight boards, et cetera, et cetera. And what really worries me, which we're going to get to on the next slide, I would also argue this question has very little validity whatsoever anyway. The majority of people that end up dying via suicide will answer no to this question. And the majority of people that answer yes to this question actually don't go on to do significant morbidity or mortality to themselves. So I would argue, I don't know how good this question is anyway. And unfortunately, it becomes kind of the entry point question to a lot of screening mechanisms, which is also complicated. So I give you some studies here to peek at. We're not going to go over each one of them, but I'll always include them. And by the way, you'll have access to these slides. So if I haven't already formally given them to your team, I will. So you can always look at them later or reference all the different studies I've got here for you. I would argue that, once again, low validity to this question, not a lot of clinical utility. My bigger concern is the very last study. Is this even the right starting point? Because my worry is a lot of people, particularly non-psychiatric physicians, use this as the whether you get more care or not. The minute you say, no, I'm not suicidal, I'm not homicidal, then they, okay, you're good. And that really worries me, because that is not a fully assessed person. That is not a risk assessment. So think of this as the core misassumption. What I would say is not that you can't use it, but make sure it's not your intro and it's not your closer. It's a part of your decision making. It's a part of your gestalt. However, really, when you're talking about risk assessment, you want a paragraph. If you are finding a way to sum it up with checkboxes and scores, we'll get to that in a bit, but that's probably not good for risk assessment. For risk assessment, we really want to get to what did you decide. I had an old mentor said, MD stands for make a decision. DO stands for do something. We are paid for and prized for our ability to make difficult decisions and then communicate them as such, not just to regurgitate statistics. Number 2, this is probably, just to warn you guys, the most contentious one that I share with people that often people have questions about, so I'm happy to go into further detail later. It seems to be the one that gets the most people kind of interested. They contracted for safety. Now, what's interesting about today's talk is I'm going to give you a lot of phrases, and a lot of those phrases are, hey, don't do this. It's not good for you. And I think sometimes people interpret that as me saying they are bad words or they are bad phrases. That's not what I'm saying at all. I know what people mean when they say this. It is neither nefarious nor evil. However, a lot of the things I'm telling you to avoid are not because the words in of themselves are bad. It's because they are interpreted poorly in the courts. The courts see them badly. And so therefore, the fact that that isn't what you meant, unfortunately, doesn't really mean diddly squat. It's how it's going to be interpreted by a judge and or a jury of your peers. And I should put peers in quotation marks. So this phrase has historical negative connotation. For most of you on this, you will not remember this. A couple of you may chuckle. There was a period back in the 80s, most of the 80s, early to mid 90s, where a lot of emergency departments were not doing risk assessments. They were doing safety contracts. And it was literally a piece of paper that said, I, Tony Thrasher, promise on this date and time to leave the ER and not kill myself. And I would sign and date it, and that was the extent of their risk assessment. They would go no further. And of course, that is very poor assessment that has no long-term validity. And a lot of people did kill themselves. And so there was a massive amount of lawsuits around this, probably appropriately so. And so the term of contracting for safety still has that historical pejorative connotation. Now, this is not the same as safety planning. Safety planning is a Joint Commission certified activity and term that I think you should lean into. But you want to stay away from they contracted for safety, or my personal favorite, they won't contract for safety, to which I always say, okay, it doesn't matter if they will or won't. That's not going to be part of my risk assessment. This is a really big phrase you got to be careful with. If you're worried about your records coming to the attention of certain legal professionals, this is a phrase you want to remove. And I still hear it a lot, particularly in the world of nursing and social work. I see this a lot in notes. My favorite article out of these 3 would be the first one. These are 2 well-known forensic psychiatrists who basically came out right before COVID and said, what's going on? I thought we had already taught everybody not to use this phrase, yet we are being brought into cases and retained in cases where people continue to use it. So just to point out, this isn't just me. You really should avoid the idea. And I know people could say, but I meant, what you meant is not going to matter here. That isn't how court works. And for those of you that have been in court, you've seen it. For those of you that haven't, it's a good reminder that when you're in court, it isn't like they show on TV. It isn't going to be about a list of character witnesses to talk about what a wonderful physician you are. It's going to be about what you wrote and how it's interpreted by non-medical people. This is not a phrase you want to be on the stand with. Instead, avoid the term completely. I have no substitution here. I wouldn't even use it. If you feel the need to put something in there, I would use safety planning. Safety planning is awesome. Safety planning, once again, is backed by the Joint Commission. It has very specific pieces to it. I list them for you here. We had a Psych ER for years. The back of our discharge form were these things. Every single person had safety steps, warning signs, coping strategies, who to call, because we are doing a good safety planning on every single person when they walk out the door. Another phrase to consider would be contingency planning. I don't think we use this enough in psychiatry either, which is ironic because most of our illnesses are not curable, right? They're chronic, they wax and wane. And so a lot of times, if you got the couple extra sentences getting into, I'm so glad you're feeling better now, but before you leave the ER, before you leave the inpatient unit, the thing that you just dealt with may come back again. How could we do things differently? How could we, the system, do things differently? How could you, the patient, do things differently? How could we find a way to handle this symptom in such a fashion that it doesn't lead you to an involuntary stay, per se? This is really good documentation, medical legally. I also think it's really good for the patient. It shows that we care about them even when the wheel is not squeaky. Number 3, building off words. Oh, doc, don't worry about that one. You know that one? That's Tony. It's not a suicide attempt. He's just seeking attention. Once again, I'm not suggesting people don't seek attention. They absolutely do. I'm not suggesting sometimes that's not the primary motivation of people that you're seeing. It is. And probably they are overrepresented in the field of psychiatric assessment or psychiatric crisis assessment. However, no matter how true this may be, I would never use these words in your notes. These words are asking for trouble. And once again, it's not about if it's true. It's about how it's going to be interpreted. And this really looks bad. In fact, this is kind of like the other side, the prosecuting attorney. This is their dream. Because once words like that are in there, they can start to head down the road of you being biased. Particularly a very bad term you want to hear, which is anchoring bias. I have seen people put this as the first line in their notes, and they are in a really bad space. Because and it's argued by opposing counsel that, look, you can tell right here, Dr. Thrasher had already made his mind up. How could we assume he gave his standard of care assessment when right off the bat, he's already diminishing this person's concerns? That's not made up. I'm quoting, I've heard this in court, dozens of times. So you got to be very careful with this phrase. I personally don't use cry for help either. There's no evidence to that. So I can't, the evidence you're going to see on the next slide is all about attention seeking. But personally, as somebody who does this a lot, I don't even use cry for help. I think I know what people mean, but I think it can be misinterpreted. I think it can be read in the note and be read as dismissive, lowering the severity of the concern, or God forbid, this right here, anchoring bias. Already establishing an opinion or disposition prior to the exam. And for those of you that remember your good old USMLEs, this is what you got to be worried about. Remember the malpractice, the 4 Ds? This is what they're proving. They're proving a deviation or a dereliction in your duty. All we are held to is best practices standard of care. And if they can prove that you didn't do that, then they are well on their way towards some degree of malpractice claim. So I would argue there's a lot of different ways to say that. And I'm going to give you a couple specifics here in a second. But I think what you really want to focus on here, what this research is showing you, is objective language, non-judgmental language. And once again, if you want to, get on here and say, hey, Thrasher, I think you're being too PC. I think you are catering towards current trends. I don't have a good argument against that. I hear you, and I don't like it always either, but it is important to protect your licensure and reputation so you can go on to treat thousands of people in your career. To me, this is the greater good, to learn how to use words that will not be misunderstood. If you think about it, we've done this our whole career, right? You guys remember we don't even use. So prior to intellectual disabilities, back when it was still called mental retardation, you guys remember that it didn't used to be mild, moderate, and severe, right? Idiot, imbecile. We've always used words that have eventually been then turned and changed and kind of worded in a different way. We have to be somewhat fluid and flexible with that. Because as I put in red at the bottom, what you never want your note to read as is trusting or not believing. And I think even with the best psychiatrists, I hear this language a lot, like, oh, this time I really believe them. Okay, well, that unfortunately probably isn't going to make it into my note. I need some more objective components of what we're talking about. Because even though your gestalt is very powerful, and I do trust it, I think all of you are probably really good at reading people. That's not how you want your note to read. That does not read like a physician. That reads like kind of a layperson, and that will be used against you. This is my choice on how to describe them. Maybe you've already heard this, maybe you haven't. It's never been patented, but me and a couple colleagues really started pushing this in residency. Every suicide attempt, rather than saying cry for attention or, seeking attention or cry for help, every suicide attempt can be labeled as medically and or psychologically significant. And I think that's a really nice objective way to get across your point that does not come into any trouble in the courts. So first up, let me give you a couple examples. And these will be stereotypical, so I apologize. 15-year-old adolescent broke up with their significant other, completely bereft and despondent. And we all remember 15, right? It's the only person for me ever, ever, ever. I'll never find love. There are not other fish in the sea, etc. To communicate that degree of sadness, they walk into their living room where their whole family is, stand in front of the TV, blocking the TV, and pop a bottle of Tylenol. Now, that is medically significant. If we don't get them to a hospital, if there isn't emesis, if there isn't NAC on board, that acetaminophen toxicity can cause significant problems. So it's probably medically significant. However, I would argue probably not psychologically significant. Even if your family hates you, they're going to call 911 just to get you out in front of the TV, right? You're going to come to attention. So high in medical significance, low in psychological significance. The inverse also exists. I think the inverse is scarier, to be honest with you. Let's say you're dealing with somebody with schizophrenia who's in an ACT team. 7 days a week, you're following them. But they're doing well, and they tell you, hey, doc, I'd really like to, leave Louisville. I'm going to go take a visit to some friends over in Tennessee for a bit for the weekend. Can you give me my meds for Friday through Monday? And then I'll see you on Tuesday. And you're like, sure, you've been doing great. Here's your weekend meds. See you when you get back on Tuesday. Except the patient then doesn't take the trip as planned. They drive to a rural part of your state. They check into a roadside motel under an assumed name, pay cash, so there's no tracking whatsoever. They put the do not disturb sign on the outside of the door. They paid for 7 days advance. They barricade the inside of the hotel room door, the motel room door, with bureaus and chairs so nobody can get in. They sit down to write a 3-page suicide note and then lay down on the bed and proceed to kill themselves with 4 trazodone. Medically significant? Not at all. 4 trazodone just give you a little bit of a hangover. Psychologically significant? I hope the hairs on the back of your neck are up, right? This is somebody who plans to die. The fact they haven't found the right lethality yet does not make me feel good at all. And I use that example. That's actually a real life example. I pulled together 2 cases because I saw both of those cases laughed out of the emergency room. And why was that? It's a failure in our assessment system. All they asked was, oh, you tried to kill yourself? How'd you try to do it? 4 trazodone? Ah, you're full of it. Get out of here. No other questions were asked. Where was the overdose? What was your planning? What was your rescue attempt? Was there no rescue attempt? None of that came up because it was 4 trazodone. They emphasized the medical significance and did not look at the psychological significance. And that's unfortunate because that's where a lot of our risk lies. Another one to think about. Oh, doc, I'm sure you guys don't deal with this in Louisville, but here in Wisconsin, people tend to drink a little bit. I know they drink in Louisville. That was poor sarcasm. The key here is don't worry about them. They're not really suicidal. They're drunk or intoxicated, right? Now, the hard part here is, honestly, the statistics can cut both ways. You want statistics that show substance use is protective? I'll find it. You want statistics that show substance use is a risk factor? I can find it. So since we have equal evidence, I do want to err on the side of caution and note that substance use disorders do provide a degree of risk. Usually people end up doing something more medically significant than they planned, and or the intoxication impaired their rescue plans or many other things that make this more complicated. So I'm not saying you shouldn't speak to substance use. I'm saying you should make sure that it's not your closure. This isn't your closing sentence. I'm going to discharge them because this is all about their intoxication. Or I rate the suicidality as low because they're intoxicated. You do not want this as your closer. There's not good evidence for it. You want to work it into the body of your paragraph, that's fine. Because We know substance use actually has longitudinal lethality. That was probably the big finding out of that the middle study that was reproduced out of the American Journal on Addictions in 2015. Is even when people don't have a history of suicide, they found them to be of higher risk of lethal attempts on their first ever attempt if you just had a substance use diagnosis in your past. So what do I suggest? First off, you have to be very cautious, and this is hard, conflating their risk versus inpatient, right? There's not a good evidence of inpatient psychiatric care for a primary substance use disorder. Even though we do it, we all do it, there's not tons of evidence. You really want, comorbid type of units or residential units or things like that. So a lot of times I think this topic gets muddied by what we are trying to solve. However, if you're looking for a way around it, I tend to always use medical examples. I find that's easier to teach other non-psychiatric disciplines. So I say things like CHF. I'm like, hey, ER buddy of mine. What if I came into your hospital with CHF? I'm off my dig. I ate a bag of Lay's. Both my lower legs are swollen. I come in, you use Lasix to get my legs back to normal, refill my dig, do a quick echo. My cardiac wall function's great, and my EF is 0.4. You gonna admit me? He's like, God, no. I'm like, but I'm at risk, right? He's like, oh, yeah, you're at risk, but I wouldn't admit you. That's a chronic risk. And I say, bingo. That's a lot of what substance use is. There's extensive chronic risk that we want to address. We do not want to ignore. But there's a lot of times, too, where it is not an imminent risk, or the imminent risk may be mitigated by sobriety or non-hospital-based options. Very similar to that one, I would bring up situation number 5, suicidality over medical problems. This is one that probably I think the data has changed the most about over the past 10 to 15 years. We've always known this was an issue, didn't always have tons of great data. I'm sure there's some CL specialists out there that probably know it better than I do. But in the end, the really take home we try to teach people is when you're dealing with mental illness, particularly severe and persistent mental illness, it's more likely that our patients will have more medical problems, not less. So even if you think the issue is primarily due to medical, you don't want to make this your closing sentence either. I have seen people who killed themselves with no past psychiatric history other than receiving a terminal cancer diagnosis a week prior, right? I'm sure you have too. I've seen cases with people with no prior psych history, but who had enough comorbid medical conditions that affected their level of functioning that they finally had decided this is no longer worth living. This is too much pain. This has taken me away from being able to play with my grandkids. I've just had enough. Theoretically, no history of major depression or other DSM-5 illnesses, but still at high risk for suicide. A lot of research on this that I mentioned. The ones I picked here really focused on other things that contribute to suicidality, sleep problems, comorbid, ever-increasing medical complications, access to care. None of these fit under, are you suicidal, yes or no, right? Yet they all have markedly more ties to whether somebody's going to kill themselves than the presence of suicidal ideation. And another thing to keep in mind here, a little bit off topic, but I'd like to include it, the idea of hopelessness and helplessness, right? That has far more predictive value for suicide attempts and serious suicide attempts than does the presence of suicidal ideation. The presence of suicidal ideation, unfortunately, is a very large denominator that often throws off a lot of its data. But when people are feeling hopeless, particularly hopeless because of some of these things I've got here for you, that to me is markedly higher risk of suicide than somebody saying, I'm going to kill myself. So very similar to the substance abuse topic in number 4, which is why I put them back to back. Think of a way to kind of document this in a chronic versus acute. Yes, chronic high risk. I don't expect them to have the similar lifespan to somebody without these issues. That being said, in the next 2 to 3 days, there's probably not tons that we can mitigate in this context. Here's what I would suggest. Here's what the evidence shows about treatment for substance use disorders. It's usually not lock them up so they quit drinking or using. There's something more to that. However you want to phrase that in a paragraph type of fashion, I think is going to work out much better for you. Another one that I think people really struggle with documenting, but I don't think you have to anymore because there's plenty of literature out on this now. I wouldn't have said this 20 years ago, but there is now. Doc, we're not worried about them. Go see somebody else. They're not really suicidal. They're just cutting. Now, to be fair, I do agree that most self-injurious behavior is not tied to suicidality. I think the evidence bears that out too. So I get what you're saying. This isn't suicidality, but you know what? It is an issue. It is a problem. This kind of like saying, oh, they're not having a heart attack, but their blood pressure is 240 over 110. But don't worry, they're not having a heart attack. Well, yeah, I get it. They're not having a heart attack, but something else is going on that we should address. Um, this is a separate type of self-harm. We could get into this, for hours. Burning, cutting, insertions. My worry is the mental health world. We've done a very nice job of teaching other physicians that this isn't suicide. I think we've covered that well. However, I think that pendulum went so far that now those other fields of medicine don't think this is serious. And it is serious. It does matter. It just means they're not trying to kill themselves in the moment. If somebody's doing this behavior, it is something we want to document. It's something we want to note, something we want to address and try to mitigate if we can. And also, I would say people really improperly reduce this to borderline personality disorder. While it is prevalent in BLPD, this is not the only place you see self-injury. See this all the time in autism spectrum, intellectual disabilities, vegetative depressions, agitated depressions. The most serious damage I've seen is in schizophrenia. That's where you really get into enucleations, removal of tongues, things of that nature, removal of genitals. So despite what people think, there is evidence that intervening in the idea of self-injurious behavior can help. It can mitigate future risk. There's things you can do here. I will argue in this third study, one thing I don't like that I think minimizes our ability to speak on this sometimes is this is often a rule out for other studies. Now, I got all sorts of concerns about zero suicide, but that's not why you have me here today. But I will say that many suicide investigations, many research studies will rule people out that have self-injury. And so consequently, our data source on that is somewhat limited, which is unfortunate. What are my suggestions for you? Well, first off, there's a lot of good things you can say here. There's a lot of accepted, appropriate terminology. First off, I tend to, you've heard me say it, I still use SIB, self-injurious behavior. That's how I was trained. In reality, probably the more up-to-date term is NSSI, non-suicidal self-injury. So call it out. You're seeing it. It's existing. What type is it? It doesn't mean it's serious or not serious. It doesn't mean they're dangerous or not dangerous. I really encourage you to reflect back to the person. What does this accomplish for you? Because it is accomplishing something, right? We are human beings. Human beings do not do things repetitively if they are not achieving a goal. It may not be a healthy way of achieving that goal, but it's achieving a goal. So ask people, and then let that answer guide your risk assessment. Last thing we want to do is say they're cutting and don't say nothing else about it, because then it's like, well, why are they doing this? Maybe they tell you it's because they've been traumatized a lot as a kid, and the person who traumatized them, they're about to see for the first time at their college graduation. Wow, now we have a safety plan. Now we got something to work with, and that took one extra sentence. That took one extra question, other than just saying they're cutting. So definitely open yourself up, and don't forget there are therapies for this. DBT is probably what's most well known, but there's other items too, and DBT is perfectly fine for this. But there's other things too. The naltrexone data is out there. I actually just saw a new one pop with naltrexone and something else that I've already forgotten because I just read it yesterday. It's not super impressive data, but it's decent. So, I mean, there are things you can do. This is not helpless and hopeless. Just because they're doing this, I think there's really cool ways you can intervene without simply reducing it to cutting. Number 7, which you guys are definitely seeing a lot of because you are an academic program, which means you treat the sickest people, and you tend to treat the people that the rest of the community will not treat or has chosen not to treat. So this one is very pertinent. Oh, doc, I'm not worried. They're not suicidal. This is just their baseline. Once again, it's okay to use the word baseline. In fact, I think you should call out when people are at a baseline. What I'm suggesting is this can't be the end of your risk assessment. That is dangerous. You can't say, I'm discharging them because this is their baseline. You need more information. Couple sentences. So for instance, what is their baseline? How do you know it's their baseline? You don't have to say every single record you reviewed, but hey, looking at the end of 2023, Tony presented in both October and November with very similar symptoms, usually at the beginning of the month after receipt of his disability check, which he then unfortunately used in a crack cocaine binge and is now dealing with crack cocaine withdrawal dysphoria. Okay? You're not judging me. Those are all objective facts. And you're showing that you know something about me, that you've researched and looked at me as a whole person. What you don't want to do is use the word baseline and then don't justify how you figured out it was baseline. I've seen people say, well, the nurses told me this was their baseline. Or my senior resident said this was their baseline. I would not use that. I mean, if you want to use it, you consulted them as sources, that's fine. But you want to have a little bit more teeth to it than I heard it from somebody else. Because chronic risk is important. We want to know what your chronic baseline is because then we can find out when it's not chronic, right? Sometimes if you work with these people long enough, you will get a case where you're like, yeah, I know their chronic baseline and this ain't it. This is an exacerbation. I need to look at my treatment plan differently today, February 1st, etc. And once again, just because they chronically are suicidal doesn't mean they don't die from suicide. So we don't want to blow these off. And unfortunately, this is one where I know you guys get it, but in a world with ever, lower numbers of psychiatrists, not all psychiatrists are the ones seeing people with suicidality, right? We have to be very careful in our messaging. So our non-psychiatric peers also make sure that they can keep their eyes on that just because they're coming to you with chronic suicidality doesn't mean they're completely low risk. And for those of you on this particular talk that are in the world of leadership or medical administration, I would point out the middle article that came out of AMJ Psych back in 2018. This really looked more at when we're complaining about this, are we complaining about the patient? Or are we complaining about high utilization? Totally different thing. Somebody may be suicidal and need help, but people become upset with them because they've seen them all the time. They've developed countertransference about this high rate of utilization, and therefore things are missed. That is often called out in court as well. So however you want to do this, I give you the paragraph I like to use. Once again, not patented, use it, don't use it. But I think it's good, particularly for those of you early in your career, to decide on some wording you're going to use when somebody is presenting with chronic high risk. Once again, if you're in a training program, I don't want to speak for your leaders here, but you probably don't see no risk, right? You probably don't see that. Yeah, you probably see low risk. You probably see mostly moderate risk is probably your baseline, just because the selection bias of who makes it to your doors. So I think people get nervous about using the word risk when they are discharging to a lower level of care, and you don't have to. You just have to call it out. So this is how I choose to do it. I say this patient may be long-term risk of harm to self. I'll even include, I think they have a lowered lifespan or an increased morbidity and mortality compared to somebody else. However, at this moment, on this Thursday, there's no clinical indication for inpatient care. Either there's nothing to modify. I've reviewed the record, and this actually reinforces maladaptive coping. There's all sorts of different ways to put it, but I definitely think you want to get something you're kind of familiar with, because whether you do inpatient or outpatient, this is a very common presentation. High chronic risk, but nothing currently acute that is drawing your attention or giving you something to mitigate. One of my favorites. Oh, doc, we're stuck. You don't have to see them. I'm just going to start looking for a bed. They have access to guns. Now, Dr. Terrell knows this is a soapbox of mine, so I'll keep it short. This is a phrase that probably is misused all the time. I'm glad that we're asking about firearms. You should be asking about firearms. The hard part is people just stop at this phrase and don't go any further, and that really kind of hurts you. First of all, access to firearms is an incredibly subjective term. In many cases, access to firearms could mean your hunting cabin 3 hours away where the ammunition is stored separately. It could also mean 9mm under your pillow with one in the chamber. Those are both access to firearms. Those are both drastically different access to firearms that you have to handle in different ways. So you want to ask questions. You want to kind of get into the weeds a bit. Oh, really good question here. Let's pause 8. I want to jump back to 7 because I think this is a nice question. From Dr. Wasim. Any thoughts on the term hospital dependence? I would avoid that. That doesn't sound good at all. And that, I hate to say it, sounds systemic. That sounds like the hospital has decided that, which then could really put your institution at risk. I think there's a different way to say that. Such as, we're worried that the person is not developing their own coping skills because they're relying upon the hospitalized environment. Or the hospitalized environment, while well-meaning and definitely trying to help, we may accidentally be reinforcing maladaptive coping by not helping the person learn how to live outside of the hospital. There you go. 2 sentences. Hospital dependence to me seems like we're really putting the blame on the person, which we're trying not to do. If we are frequently admitting somebody, then wondering why they're not doing well in outpatient, we own some of that responsibility too. I would try to call out that nuance. Really good question. Never been asked that one. Moving on, back to our firearm question. So when you ask access to guns and they say, yes, doctor, that's not the end of the conversation. That's the beginning of the conversation. What is their access? How do you use it? I have found this phrase makes a lot of people in our world of mental health care become learned helpless, which we don't want to, you never want to practice from learned helpless. That's a very disadvantageous position to be practicing from. So we want to empower ourselves. Okay, you have access to firearms. Let's talk about it. I'm excited to talk about it more. There's a lot of things we can find out that'll either make us feel less concerned or more concerned. Because once again, we do care about firearms, right? This is not going to turn into my firearms talk, although I'm happy to do that at a different time, which is we're worried about suicide, right? This is where mentally ill possessing firearms, I am not worried about harm to others. I'm really worried about harm to self, particularly since it's highly lethal and it happens really, really quickly. I cannot say enough how important it is to think about guns when you think about suicide. To actually not talk about it, to me, is like a cardiologist not talking about smoking. Like, we have a risk factor that is the highest risk factor for an adverse outcome. How do we not talk about it? So what are some suggestions? I'll also say, if this topic kind of if this topic is of interest to you, I have some stuff online that's free. I do a bunch of mental health minute webinars for psychiatric time. So if you Google my name and how to talk to your patients about firearms, or my name and psychiatric times, you'll find this. I do like a 20-minute thing on how to talk to patients, what 4 questions you should use, etc. It's all free, no financial investment. But you want to ask things like, why do you have it? People have weapons for very different things. I also think a lot of times people don't understand it's a risk. They don't think it's a risk because they're not suicidal. However, they will then literally tell me, I'm really stressed because my kids are suicidal all the time. To which I say that, we should really get that firearm out of the home, that there's risks there. But the biggest thing is, you got to have this talk. You got to take the time to talk about it. Otherwise, we are really missing out on opportunity. And there have not been tons of legal findings as of yet, but as someone who often tries to have their finger on the pulse of the medical legal community, it's coming. There's enough evidence now that the medical community is not asking about this, is not screening for it. At the same time, there's tons of public health data showing that asking about it, screening for it, reduces suicide at a population level. Once those two things come together, evidence that there's something that works, and we're not doing it, you're going to see lawsuits. So it's not here yet. I'm not telling you that at all, but I can see that coming. That seems to be the next thing on the horizon. So have the gun talk. It's not always comfortable. As some colleagues of mine from Pittsburgh put it, it's kind of like having the sex talk with your tween or your adolescent. You don't really want to have it, but if you don't have it, somebody else is going to have it with them, and you may not like that. So really get into talking about this. There's tons of awesome things you can document here. You can document what type of access. You can document that you educated them on the risk this poses for suicide. You can document on how you offer different safer storage items, gun locks, gun safes. There's all sorts of things out there. And believe it or not, there's a bevy of research on what gun owners would like and what they prefer and the types of messaging. So if you want to, I said I wouldn't be on a soapbox. I'm on a soapbox. So I will step off said soapbox. But needless to say, there's a lot on this if you have interest. And maybe some of you are already subject matter experts and know this. I would ask you to please continue to propagate it. Number 9. I would argue this is the toughest one for me. Maybe for you guys too. I don't know. They're not suicidal, doc. They're homeless. They're out of money. They lost their job. I find these to be incredibly difficult because I think we have a cognitive dissonance here. Like, we are all, not all of us, but I bet you most of us are pretty helpful people. We like people. It's why we do what we do. And you want to help them. And yet, these are things that really don't easily fit into our toolbox, right? This doesn't fit easily into diagnostics and psychopharmacology and sometimes even psychotherapy. So we get really, I think, flustered by this, when in reality, guess what? These are risk factors for suicide. And there's plenty of examples where being homeless is a significant risk factor. Being transiently housed is a significant risk factor. So I don't think you shouldn't talk about it. I think we should talk about these things. What I'm saying is, I don't think this ever serves as a reason to say, no, they're low risk. If anything, it may say they're at high risk because of this scenario. However, we can't mitigate it with our current treatments. We're going to refer to something else that could mitigate it. So don't say there's nothing we can do. There are things we can do. It just may not be at our site. They may be at McDonald's looking for prime rib, and we don't offer that on our menu, but how can we get them to where the prime rib is, so to speak? There's a lot of social. In fact, I can't speak to your population data, but I will speak to Wisconsin's. We have found the majority of completed suicides statewide, medical examiner data that is then investigated by mental health professionals, shows that a lot of people that are killing themselves are first-time callers. They are not your chronic access to. They are not ACT patients. They are not high utilizers of hospital services. They are people that are facing some significant ego blow, some significant stressor, and in that 24 hours, they have chosen to end their life. And that's very scary because those are hard to get to, but we got to start thinking about it with our documentation. And I already mentioned here, we do have data on homelessness carrying risk. We have data on being a non-cis, non-heterosexual approach also is a significant risk factor. I think that data is better known, but I think people still don't document it or talk about it as much. And when it comes to homelessness or houselessness, I often, I think that's another one, kind of like the gun question. Like, if you say you're homeless, answer yes, that's just the beginning of my questions. Now I'm curious, like, how long has this been going on? When was the last time you were housed? How can we recreate that scenario? Why did you lose that scenario? Oh, it was due to psychosis? Oh, okay. Well, let's see how we can work on your psychosis and work backwards and try to get you back into a housing situation. There's a lot of things we can do that don't fit into check boxes in this particular context. So once again, call it out. I'm not suggesting you don't call it out. One of my things I dislike the most about the DSM-5 is we got rid of multi-axial. I really enjoyed the multi-axial system. In fact, that's how we would teach our trainees when they came in the ERs. What are we looking at here? Is this axis 1, 2, 3, or 4? Because usually one of those things was leading the charge. It doesn't mean you didn't have the other stuff, but which one of those was the kind of instigating reason for why they were in front of you at 3:30 in the morning? And I think focusing your treatment on those different axes is very important. So call it out that it's psychosocial. And what did you refer it to? How did you use it? How did you try to mitigate it? You want to call out the risk, even if it is not a risk that you directly can mitigate. That's okay. The courts understand that. You are not meant to be a genie in a bottle. But if you don't call out the risk, then the argument's going to be you didn't assess for it, or you weren't paying attention, or you didn't care. All right, number 10. We are making good time. Doc, can we just get them out of here? They're just threatening to get their way. Once again, people do threaten. People do threaten to get their way. People do manipulate and threaten to get their way. I fully agree. I am not naive. These cases do exist. What I'm suggesting is you don't write your note like that. This is another one going back to the cry for help or seeking attention. If this is in the early part of your note, you're kind of toast, because they can easily play that then the rest of your note is biased. It's fruit of the poison tree. You don't believe them. You don't care about them. You don't like them. One could even argue you're scared of them, which, by the way, you have every right to be scared about them. I've seen that play out on the stand where a doctor's like, yeah, I was honestly scared about them. And then the lawyer will still try to use it as a reason to why you didn't provide standard of care. So it's okay to note that threats are occurring, but please don't make this your chief complaint. Please don't make this your closing argument. If anything, I think it requires, again, you're probably sick of hearing this, more questions. If they are threatening, is this the first time you've ever seen them threaten? Are they normally calm and collected and now they're threatening? That's weird. Are they threatening all the time? And this is the baseline. If you can get the person a bit more calmed down, try to understand what the threat is about. In other words, they were saying they wanted to kill everybody. However, when I sat down and chatted with them over juice and a sandwich, what they said was actually they were dealing with problem getting their medications, but they find that when they say that, nobody pays attention. When they say they're going to kill people, people pay attention. And that's true, right? Unfortunately, we have created a system where that is accurate. Our patients are incentivized to speak to dangerousness, whether it is present or kind of present or not present at all, because that's what gets them in front of us. And I'm not saying everybody's like that, but a lot of systems are set up that way. And it's unfortunate. And then we wonder why patients do that. Once again, human beings do things to achieve a purpose, particularly when they do it repetitively. So when you see somebody threatening, my first thought is not, hey, what a jerk. My first thought is, well, this must work for them pretty much in their life. It's not going to work today in this emergency room, but it probably does work for them everywhere else. That's why they keep doing it. And once again, it may go down the road of contingent suicidality, which you guys may already be familiar with. Tons of literature, right? This is the, if you don't, I'm going to kill myself, or if you do, I'm going to kill myself. It's all threatening based. Tons of good literature. Most of it is out of UT Southwest. Dr. Lambert and his group have done good proactive and retroactive studies on the topic if you want to dig in. So you can use the term contingent SI in your notes, and it's very protective. It's a well-validated term. Most people, if the only suicidality they have is contingently based, they are typically at lower risk than the general population of killing themselves. Now, I don't reflect that back to the patient. I think that makes it adversarial. I think that leads into a you're lying or you're deceiving me type of thing. So this would be the difference between how I approach the patient and what I choose to document are two different things. But you don't want to reduce people to one thing or another. You can say they're presenting with threats. I then tried my best to ask the person, what is it that they need? How can I help them? I also very transparently noted that while they are threatening, it's becoming very difficult to help them, and I want to help them. And I say that all the time. I'm transparent when I'm, kind of in my secure spot and maybe there's a divider between us, and I say, listen, I'm here to help you. I want to help you, but I got to be honest with you. You are scaring the crap out of me. And I do this for a living, and you scare the crap out of me. It's going to be really hard for me or my team to help you if we're scared. We don't want to be scared of you. Can we work on something? Can we talk in a different way? Can we have a different tenor? And then usually, unless it's being driven by psychosis or mania that has not yet been treated, usually people calm down and then they can tell you what they meant by threatening. And that's what you want to document. There are very few things that are better for you in documentation than quotes, because quotes cannot be held against you. Quotes are quotes. That's what you heard. That's what you put down. So if the patient can eventually say to you, I didn't really want to kill anybody, doc, but it's like the only way that your security guards would let me in the door. I'm writing that entire sentence and quoting it because that is really good medical legal documentation, as opposed to you saying they were threatening, but they didn't appear to be all that serious. Whew. Buckle up, because you got about 15 minutes of cross-examination coming your way, because there's a lot of judgment in there. There's subjective opinion that you're going to have to answer to. If you're putting in a quote, there's not much to say. Did you hear the person say it? Yes, I did. Okay, sir, you may step down. There's nothing to be said. It is what it is on a quote. So once again, you can use contingent SI. I think it helps if they will admit it to you, or if you can try to get to it. What is the perceived need that you think the threat is trying to get to? Remember that a lot of our patients, actually, I'm going to go a step further. A lot of us, all of us, when we are in crisis, you know what happens? We lose a lot of our intelligence. I know I'm sitting here using all these cool words and we're talking at this really high level, but you put any one of us in crisis, we're not like that. Frontal temporal turns off. Hippocampus and amygdala get ramped up to 12, and we're just like anybody else. So a lot of times, even though they're threatening, I would argue it's not even threats. It's issues with communicating during a time of crisis. So the more we can get to, what are you trying to tell us and how can we help? Suicide's a great term, right? I'm suicidal. I'll say, okay, I hear you. And I'm sure you've all done this. But that being said, I also know that things are really tense around here, and suicidal means a lot of things to a lot of people. Could you tell me what you mean? Well, I'm just so damn frustrated that I can't get my SSI. Okay, you're frustrated, and you're rightfully frustrated. But now we can take it off the world of suicide and start talking about something else that we can mitigate. So in other words, try to get there if you can. And then I would close with this. I personally don't use these words. I see them in notes all the time, and I just start to I start to crinkle up. I wouldn't use gamey, manipulative, lying, playing. Once again, you absolutely deal with manipulative patients. You absolutely deal with gamey patients. I am not pretending these phrases are not accurate. I'm saying the court does not care if they're accurate. And you know who else really doesn't care? A jury. A jury sees this stuff, and believe me, we already live in an area where expertise is somewhat frowned upon. That's a whole other philosophical discussion. It does not take a lot for your average jury member to be turned south against a physician. Don't help them by putting these words in your notes. All right. How are we doing on time? We got a little bit extra time here at the end. So before we bring you guys all in and do some more questions and stuff, let me hit you with some extra credit. This is my speed round. It'll go beyond number 10. I'm not going to do all 3 slides. We'll just do 1 slide per comment. I think these are important. Maybe not the top 10, but they deserve to be mentioned. Honorable mention, if you will. First up, everybody's favorite. Doc, I'm stuck. They screened positive. We do not have enough time to go into the topic of screening. What I will say is, you're screening, I'm screening, we're all screening. I'm not here to rail against that there should be no screening. It is present. It is here. We are doing it. What I think you have to be very careful, and not as much you guys, but the non-psychiatric, non-mental health people that also work with our patients, is not to count screening as risk assessment. It is not. And in fact, I have seen defense attorneys, or pardon me, prosecuting attorneys use these studies to say, doctor, are you aware that your own professional literature does not back screening as risk assessment? And then people's faces just fall. So unfortunately, we are in a system where we are having to do something that necessarily does not have evidence behind it. That's a whole nother can of worms. So do it if you have to do it, because it's part of the system you're in, but please make sure you're passing on to everybody that's using these. This is not risk assessment. This isn't even within the arena of risk assessment. Number 12. This comes up a lot, and I will be very transparent with you. I did not research Kentucky's laws on this, so I will give you kind of my view globally, but I understand that your laws may have some discrepancies to them I'm not familiar with. I must do this, doc. I got a duty to warn. Quick reminder, most states no longer have a duty to warn. They have a duty to protect. Drastically different scenario, but I see people put in there, in Wisconsin, we have a duty to protect. I see in the notes all the time, my duty to warn says, and I remind them, I like what you're doing. I think what you're doing makes sense, but just so you know, you don't have a duty to warn. You have a duty to protect, which may include a duty to warn, but it doesn't have to include a duty to warn. There's a lot of different things you can do to protect people. So this is another one where the theme behind it is fine. When we speak to confidentiality, my take-home comment is always, it's not about did I break confidentiality, it's about did I explain why I broke confidentiality. That all applies, but don't ever make your closing like I had to do this. I didn't want to do it, but I had this duty to warn. You better make sure your legal ducks are in a row if you're going to use that as your closer. Doc, they're just a borderline. The irony here is borderline personality, as many of you are aware, is one of the original mental illnesses. If you want to be a taxonomy nerd, go back to the DSM-2 and 3 and the FINER criteria, FEIGHNER. This illness has been around forever. It's a real severe illness. It's very damning. It affects people. It has significant morbidity and mortality. Some of the biggest disability scores that we've ever seen are from BLPD. And everybody kind of craps on it and pushes it to the side and says it's not treatable, or these patients are just trying to no, these people's lives are hell. They are not enjoying themselves. So once again, I'm not saying you shouldn't use the term borderline personality. It is a diagnosis that we diagnose. What I'm saying is when you phrase it, make sure it's not just a one-liner, because unfortunately, the courts have caught on. The courts know that healthcare professionals don't like these patients. The courts know these patients are likely being marginalized or kept out of services. They're going to use that against you. So whenever I have somebody whose clear primary diagnosis is BLPD, I'll say, I think what we're working with here is borderline personality disorder, as evidenced by poor sense of self, intense, often transient relationships with others, transient psychosis during times of mood instability, and et cetera, et cetera. You don't got to do the whole 5 out of 9 from the DSM-5, but toss a little bit of extra data in there, just so that people know you're not just doing this because they cut themselves or because they have frequent presentations to your emergency department. This is one of those where, once again, it's not fair that you're being judged by this, but in the courts, this is a diagnosis that people know are not getting a fair shake, and so that could be used against you. Remember when I said the first one mattered and the last one mattered? We're on the last one. No more tricks, no more extra credit. This one I leave last because I also think it is of extreme import. And it goes back to my whole joke about being sued. I find a lot of people who will say, hey, can you come talk to our group? We need to work on our defensive practice. To which I then say, oh God, why would we do that? This is what the opposing counsel will be trying to prove. Once again, to be held liable for malpractice, you have to have deviated from what is considered to be best care, standard of care, right? Doesn't mean that you did the best. Nothing in the court says you have to be an A+ doctor. It says you got to be a C+ doctor, right? So they're trying to prove that you were a D- doctor. So whenever you use the word defensive or I practice defensively, you are literally handing ammunition to the people that are trying to prosecute you. You are proving that they're right, that you were scared, you didn't like them, and you didn't follow what you should have followed. So this one you really want to wipe out of your vocabulary and instead take home what I put here in green. Best practice is not to practice defensively. Practice evidence-based care for everybody and learn when to document defensively. Don't practice defensively, document defensively. And that is not just me trying to be fun with words. That's a drastically different scope. And usually when you instruct people in it, they see that and you can watch the machinations happen. Like, okay, so I'm going to keep on doing what I'm doing. But when there's certain cases that I'm pretty sure somebody's going to be reading my note one day and that's not going to be the patient, how does it look? Should I document defensively? Should I spend more time on it? Should I do a consultation? All of these things are incredibly important, and they're not always the easiest to write up. So I just remind everybody, the most common reason that we are successfully sued is not suicide. Now, the most common lawsuit in psychiatry is suicides, but most of those lawsuits are either dismissed or they are settled. They are not adjudicated. If you're actually going to be in a courtroom and it's going to be going towards a court decision, it's markedly more likely they're going after other things that I list here. Things such as the language in your notes, informed consent, elopements, civil rights, confidentiality, boarding process, denial of care. That's what people are being adjudicated in a negative sense for. So just keep that in mind. Don't get so focused on the suicide component that you miss out on all the other things that could get you in trouble. Whew. We have made it. We still got some time here. I got a couple last slides and I'll open it up for some questions. I've alluded to this a couple times, and if this topic is of interest to you, I do an entire separate talk just on this. It's kind of the follow-up to this. It's like, after what not to write, how can we use our notes in an engaging, empathic fashion? And this is one of the pieces. We are now in the era of the open note. If you guys aren't there, you will be there shortly. It's become a federal requirement. Every state and system is doing it a bit differently, but we are needing to open up our notes. It used to be psych could kind of hide from this. They cannot. Now, this article I reference is behind a paywall, and I don't want you guys to have that. So I did cut out an important slide, and I give this to you here. It looks like it's very small print, and it is, but I will give you my slides so you can blow it up. But these are some other items to consider when you are writing your notes that are really geared towards the fact that they are going to be read by the patient's families, and something else that we're finding out in this is not only can they read it, in reality, it belongs to them. That's what the courts have decided, is that documentation belongs to them. So what I have found that's really, really interesting is actually some people that end up doing this type of thing, and they know the patient has it, but then the patient shares it on social media, and that is not against the rules or law. Lastly, I come to you from the AAEP. Dr. Terrell is also an officer with us, a big leader in AAEP, so you can talk to her about this as well. But we are a large APA affiliate. We do a lot of great things with both psych and EM. If you have any questions, there is the website. It's got really affordable fees for attendings, let alone residents. And we have an annual conference that is always in December. It is a really well-attended conference. Most people that attend one then attend an average of 4 more. That's how much they like it. And we do a lot of education, usually in 15 to 20-minute snippets. So we're really going for high yield, a lot of information, things that I think you would benefit from if you want to look into that too. And with that, guys, I am done. I will stop my share and see if you have any questions that you want to bring forth, or not even questions, comments, criticisms, other thoughts. I think there's a lot of nuance in this area, so I open up to the floor. Any questions on your end? I have analytic training in my background. I can sit here forever. Will not you don't have to raise your hand, guys. You can just unmute and holler. Who wants to go first?
I'll go first. Thank you, Dr. Thrasher. I actually thought this was very interesting, and I can't believe how much I needed to learn about the topic. I don't know whether you would know anything about this, but I was curious if you had any thoughts, since I think it's relevant to your field. I was talking with one of my mentors recently. They had mentioned that patients, specifically men that have pancreatic cancer, are shown to have an extremely high risk for suicide even after surgery. Do you have any thoughts on why, or any ideas on how we navigate patients like that?
I don't have any knowledge as to why that is, because that's the irony, right? Is I think what that data source showed is we assumed once it was treated, it would like go down, like the risk would dissipate because hey, you beat the odds, you beat pancreatic cancer, but that's not what the odds show. My guess would be it's something a bit more that you can't quantify in a lab, which is soul and spirit.
Mhm.
I think once you have gone through something like that and the rigor that it takes on you, even if you've survived pancreatic cancer and you've had a go of it, I think there's also just concerns about facing your own mortality that often, once people have started to think about suicide, they've kind of broken through that first wall, right? A lot of people will tell you,
Yeah.
I can't understand suicide. I've never even considered it. I'm like, well, some people do. And once you start considering it for any reason, then you've lowered that threshold, right? I think that's what they're getting at. I don't have a good answer, though. I know the data source you refer to, and it's a good one. I just don't have the answers. I think how to approach it, I would refer back to, I think it was my topic 4 or 5, the one with medical conditions. If this is your patient, even if they're not suicidal, even if they are hopeful and happy after their surgery, I would still say, hey, listen, the very fact that you went through this puts you at some risk, and I want to be there for you. So anytime you start getting a lower mood or start thinking about things that aren't so positive, would you please dial me in? I do the exact same thing if I'm working with somebody whose parents killed themselves, right? And they're like, well, I would never do that. It destroyed my childhood. I would never do that to my kids. And I say, I hear you, but the very fact that your biological relatives killed themselves puts you at a risk. And I want to be aware of, same with addiction, right? We see this all the time. People are like, well, I would never do that. I grew up with that. I hear you, but please don't consider yourself fully safe or bubbled away from that because you have a risk. That's how I would approach that pancreatic case. They're tough.
All right, thank you. That was very helpful.
And if you figure out the answers, you email me back and let me know. But I do not know the answers to why that is. Those are just my hypothesis.
So I see all of the psychiatric referrals from our cancer center. And I think that some of that has to do with the total lack of control. And, you know, if you have lung cancer and you were a smoker, some of that might make sense to you. But this is a cancer that there are very few behaviors that led into it. There's a sort of a random element to it. And let's say if you had breast cancer, there are things that you could do to monitor to see, has it come back? Are there red flags or warning signs that I can be aware of? With pancreatic cancer, it's a total, any bodily sensation they worry, is that the cancer? And there's no one red flag. So I think that has a lot to do with it.
That is phenomenal. It all makes sense, and I had not thought about that. Thank you. That makes a lot of sense. And you know, and the things we do know about suicidality, we mentioned helplessness and hopelessness. The other thing is rumination and lack of control. A lot of the, so I love what Dr. Casey kind of just brought to the forefront is it's literally, it shouldn't surprise us because this person is now covered in one of the main risk factors for suicide, which is lack of control.
Yeah,
Doctor, I'm going to pronounce your name wrong. Dr. Khalil?
Yeah, it's Khalil.
Khalil, my apologies, sir. Go ahead.
Yeah, I just wanted to get your thoughts about one of the problems we have here is chief complaints. Sometimes the chief complaints are, you know, they look very bad on paper. For example, a patient is manic and is threatening to kill somebody or stab somebody, for example. And, you know, that kind of gets cut and paste. And, you know, with the .emr, you see it for every note. Then when the patient gets a lot better and they need to be placed in a facility, that's the first thing these facilities look at. And, you know, it's hard for, you know, first impressions make a big difference. So they look at that and, you know, they don't want to take the patient because, you know, the patient came in really violent or agitated, but even though they're not like that on all the notes. So there was some talk about, you know, can chief complaints be changed over time? You know, you adjusted. I know Medicare tells us that we should, you know, use the quotes of the patients as your chief complaint. You know, it'd be easier to place a patient to reflect a current chief complaint because they're doing better. What are your thoughts about that?
I think it's, you hit all the high points. I do think for the purpose of billing and CMS and everything else, I would always say your chief complaint is a quote. But I have seen places where you can change it over time. So if their original chief complaint was, like you said, I want to kill these people because they've put chips in my brain. And then 48 hours later, after medications and sleep and sobriety, and you're trying to find placement, it has changed. I think you can see then people have put, like, you know, brackets after treatment and resolution of target symptoms, the new chief complaint is such and such. It all depends upon your EHR with how much free space you have. I'm also a big fan of, and this is hard because we aren't always the ones putting in the chief complaint, right? But if you have the power that you're the one putting in the chief complaint, and it's not, or this is more instruction to nursing further upstream or triage further upstream, is I remind them, you know, chief complaint is somewhat of a clinical decision. It's not just the coolest thing that they said or the most scariest thing that they said, which is why I really think it should be a physician-led EHR decision, because you're really deciding after assessment what is their chief complaint, because there's usually many things you could pick. So when I'm working in a system where somebody else other than the doctor is putting it in there, I'll say, listen, what you just said, what you pick here has a great deal of effect on the patient, both now and future state. It's not very patient-centered or trauma-informed for us to pick the sexiest thing to put in there. So think about all the different things they said. Is there something else that can still communicate their concern that isn't quite so dramatic? And that's not to say we shouldn't communicate threat profiles and risk assessments. That's how I've seen it worked around. A lot of it depends upon who's putting it in and what your EHR allows you to do to amend it. I don't know how that stands on your guys' side.
Yeah, yeah, we can change it. The problem is that we don't have, when they come in to us on the inpatient, it's already put in by somebody else and it's kind of stuck there. So that becomes a problem.
And there's a bigger
Yeah.
issue there too that I think you alluded to, that isn't I mean, we can't fully solve from a documentation standpoint, is I bet your notes are good enough to undo that chief complaint, right? If they read your whole note,
Yes.
I bet your note says something about, yep, they were doing pretty poorly, as you can see from the chief complaint. However, based upon our excellent therapeutic interventions, they're now doing a lot better. But the question is, why is that possible transferring or receiving facility not reading the whole note?
Yeah.
Why are they anchoring on the chief complaint is probably more of a systemic issue that we can't fully solve with documentation, but there's a couple little ways to lighten the blow. Good point. Really good point that I see all across the country.
Thank you.
In fact, there's off the record, I believe CMS had conversations about chief complaints in psychiatric notes needing to amend that or remove that because of this very thing we're facing. It's not really patient-centered, right? It's not, we don't do this with any other medical condition. If I come in with 10 out of 10 chest pain and then they get me out of that, they don't try to send me to a cardiac rehab with 10 out of 10 chest pain. And so it's really interesting how the stigma and the bias continues.
Thank you, Dr. Thrasher, for all of your wisdom. And I did have a question. We're a little late to the safety planning game in our psychiatric emergency service, embarrassingly so. We are doing it on our inpatient unit, and we are trying to determine sort of what subgroup of patients we would do safety plans. I noticed that you said you were in a practice area that did it on all. How do you manage the safety plan on the patient that is saying they're suicidal, that you don't believe to be the case or at risk, and you've done all the full assessment, documented all the things, but they are going to voice it literally as they walk out the door? How do you resolve that while doing a safety plan? Do you exclude them from the process? Do you write why they're saying it and they're not? How do you handle that?
Well, I think there's probably what we should probably define is what your team or your system is meaning by safety planning. So for me, safety planning, when we used it, I very rarely am like go Joint Commission, but this is one the Joint Commission did pretty decent on. They were very clear in what safety planning is, like a branded term. And what's really interesting is in each of those categories, it has nothing to do with whether you're currently suicidal or not. It has to do about when you are suicidal, which maybe that's now, maybe that's every day, maybe that's 3 months from now. It's all about prepping and planning. So I think if you want to follow it to the T and use those 4 sections, you can use it on those people quite easily, because you're not saying safety planning isn't risk assessment. It's a component of it, right? You're not saying I'm safety planning you because you're not going to kill yourself. What I'm saying is I'm safety planning for when these symptoms emerge, which could be now or tomorrow. This is how you're going to handle it, which may include return to the ER. It may mean, you're going to put in there all the things you need to do. So I definitely would not exclude those people. I think that puts you at risk.
That was my thought.
Yeah, that's what people are going to be looking for, those patients. I would not exclude, if you're going to decide to use it only on certain people, I would definitely use it on the people that came in with some degree of suicidality. Because what was always hard for us was safety planning on people who they were there for a refill of their Depakote.
Right.
Or I need to sober up before I go to work.
Right.
Those are harder ones, but we still kind of fit them in there. But if you're truly doing just the Joint Commission safety planning, it's never in there. Do you have to say, are they suicidal or not? I think that's a different conversation about how are you documenting your decision to discharge a suicidal individual, right? And that, I think, is a very fair question. It's a very concerning question to all doctors. But I think the key is that you're documenting the suicidality as one of 2 things. It's either chronic with nothing currently acute to act upon, or it may be more of an acute thing, but there's nothing currently we can do to mitigate it. And that's what you are legally held liable for. It's not the presence or absence of death. It's, did you have something you could mitigate? And so I think that's how you tend to do it. Or I think it was my slides, the 7th topic, you know, here they are. There is suicidality. That being said, there doesn't appear to be anything we can mitigate. I'm worried that further admission is going to reinforce maladaptive coping. In fact, I've reviewed the record and it appears that it does. For instance, they're actually supposed to start their IOP tomorrow. And IOP is actually proven in this population to reduce suicidality. So me hospitalizing them not only will not mitigate the problem, it's going to keep them from the thing that will help the problem.
Right.
I think kind of looking at the term of mitigation will help with that, but I don't think it has to cross over into safety planning.
Okay.
Unless, of course, like I said, when you guys say safety planning, you're meaning documenting the current suicidality and what's happening. But if it's just true safety planning, that's what I like about it. It's just basically saying that you thought about the person and you prepped them for discharge. When this happens again, not cross our fingers and hope it doesn't happen. When it happens again, what are you going to do? And so it's a really nice thing to work into. It helps for me, it helped my physicians feel better about discharging people because I felt like they were giving them some impact and some involvement. It also is a good reminder to the patient of some of the protective things they've got going on.
Okay.
Because when they present suicidal, of course, it's a communicative issue. Their mind is focused on the negative, maximize the negative, minimize the positive. And as you sit there and safety plan, I've had patients look at me and say, huh, I forgot about them. Yeah, that'd be a good person. Or, huh. All of a sudden, I'm like, you know, there was this thing full of blanks and you said you couldn't fill any of it and you filled 3/4 of it.
Right.
So there are some things. It's a neat way to put people in a more positive sense of mind before they walk out the door. Does that make sense?
Makes complete sense. Very helpful. Thank you.
Yeah, like I said, I am not a Joint Commission stan. If anything, a lot of my talks have very negative JCO things. So I'm sorry if any of you there are JCO folks. But this is one that I think they kind of hit it on the head. It's a really neat way to document that gets us out of the dichotomy of are you suicidal, yes or no. It's much more consistent with like how we handle cardiac patients or renal patients. It makes it a little bit more across the board standardized.
Thank you.
I'll bring up my own question, only because somebody said it earlier, so it tickled my hippocampus. Dot phrases. Once again, I'm not here to critique or rail against DHRs. We have them, they're here, we're dealing with them, right? I would always be very cautious how much you're copying and pasting on things like this with risk assessment. If you are a copy and paster, if you are a dot phraser, I'm not here to judge you. I would just highly suggest that when it's time for your risk assessment paragraph, write it unique. Don't carry it over. Because once again, that's what the courts are going to focus on. Unlike what was mentioned earlier, where they're looking at the chief complaint, they're going to look at your assessment and plan and what your medical decision making was. And I have seen lawyers pull subsequent records and show that like your assessment plan was the same for like 7 different people. That doesn't look good. So I'm not saying don't use it. I'm not saying we aren't all short on time and that EHRs and dot phrases have some ways to speed things up. That's cool. I would just suggest when it comes to this one particular part of your note, the closing, decision-making, risk assessment kind of summary, I would do your best to try to write it organically every time.
I was told by an attorney if it could apply to multiple patients, then you weren't doing it right.
And once again, I don't agree with it, but it's a great legal argument. So that's me and Christina do a lot of work with lawyers. And so we understand how this works. It's like, I don't agree with you, but boy, that's a really good argument. That's going to be hard to disprove in court. Because it's a great argument that we aren't being patient-centered and specific and et cetera, et cetera. So even though we know that for a lot of people, we could write the same thing and it still means that we care and it's applicable, this talk is not about what's right. This talk is about what can protect you. All right, guys. Well, I'm not going to make you sit up. Were there any other questions?
We are getting some requests for your slide set. So how would they go about getting that?
I will, once we're done here, I know I thought I sent it earlier, but if not, I will send it to Dr. Terrell and somebody else was running the show. Whoever organizes your grand rounds. I will send them the entire slide set. You guys are welcome to use them, print them off. All I ask is if you actually end up using it in a presentation of your own, please attribute it as such. That's all.
Fair enough. Thank you again.
Thank you guys. I know this is kind of a unique, nuanced topic, and If you're like me and you think more about this and this has caused more questions than answers, feel free to reach out to me via email and we'll continue the conversation.
Thank you so very, very much.
Absolutely, guys. Have a good one.
You
Stay
too.
safe.
Bye.